thermography a diagnostic method? Does thermography a diagnostic test? Yes or no? If you put yes, does it really diagnose? If you choose no, if it doesn't diagnose, so what's the point? Of course it diagnoses if you're a doctor or a specialist. What I want you to understand is that if the exam is not performed by a qualified professional for diagnosis, it is not diagnostic. The person interpreting the exam has to contextualize it with the patient's clinical situation. And what should this thermography be like to be diagnosed? Thermally controlled environment, correct positioning, analysis of region of interest. Believe it or not, but point-of-care infrared image done in real time is more diagnostic than thermography with subsequent analysis of the images. Welcome to Minutes Medical. Let's start with this topic and complete explanation. This is a paper that I participated in as academic editor and published on this topic. Use of infrared thermography in medical diagnosis, screening, and diseases monitoring, scoping review. The authors used the keywords for thermography and infrared image and found respectively 81,000 and 36,000 papers. This graph shows that 41% of the publications were in the area of screening, 26% in monitoring, 23% in diagnosis, and 8% in normative data. Point of care infrared imaging is the future already here. Today, we are going to dive into the world of point-of-care infrared imaging. Imagine being able to analyze a patient's clinical condition in real time without having to wait for results. That's the advantage of infrared imaging compared to traditional thermography, where images are captured and analyzed later. This technology offers faster, non-invasive diagnostics right at the point of care. This is my colleague evaluating a player with infrared point of care. Oops, I've just revealed the secret of our Brazilian national football soccer team. I can say the player's name now. Let's go. With traditional thermography, images are captured and later analyzed in a separate setting. But with infrared imaging, we can evaluate patient's condition in real time, making immediate decisions about the treatment. The ability to do this on the spot, especially with portable devices, is revolutionary. This is the multimodal infrared imaging point of care or POC IR. To get the most out of infrared imaging, you need a qualified professional. It's not sufficient to be a thermologist. You must be a medical specialist or a qualified professional to a specific area to interpret the images within the patient's clinical context. It's not reading just the image, but the clinical context. Whether it's an orthopedic specialist, a vascular doctor, or a sports medicine expert, or chiropractor, or osteopathic, the key is knowing how to interpret what infrared images are showing in your field. Just like you don't expect a generalist to interpret an MRI, the same applies here. How will a gynecologist would treat the uterus, give a diagnosis of brain diseases as a neurologist does? The same happens with musculoskeletal infrared imaging, for example. But let's talk about biomarkers. What means biomarkers? A biomarker is something we can measure that gives us insight in a biological condition. For example, just like a dog wagging its tail means it's happy, a rise in body temperature can be a sign of inflammation or infection. These markers help us understand what's going on inside the body. Biomarker means that something can happen. Take care. And I'm seeing this with my infrared eyes. Biomarkers are incredibly useful for many things. They help with diagnosis, figuring out what stage the disease is, staging, monitoring how the disease is progress, and determining how well a treatment is working. In short, they guide us through every step of patient care. Biomarkers come in two categories. Extrinsic biomarkers are things outside the body that affect health, like cigarette consumption, stress, pollution, fast food, and intrinsic biomarkers are measured from within the body, like blood pressure or serum levels or temperature. Both types help us paint a full picture of patient's condition. Infrared imaging falls under intrinsic biomarkers, specifically in the categories of physical and physiological markers. It fits into physical markers because it visually captures variation and surface temperature, which are physical characteristics of the body. It also falls under physiological markers because these temperatures change are linked to the underlying biological process, such as blood flow, perfusion, and metabolic activity. For example, inflammation and abnormal blood flow create heat patterns, and infrared imaging detects this, offering non-invasive insight into what's happening inside the body. A surrogate biomarker is an indirect indicator that helps us predict what will happen with the patient. It's like looking at a clue and making an educated guess about bigger picture. For example, an increase in body temperature might be a surrogate biomarker for infection. Why use the word surrogate and not just biomarker? Because surrogate biomarkers don't tell us directly what's going on. They predict clinical outcomes, but they are not the final answer. This is the point. They are still incredibly useful for guiding decisions and are not the final answers. So infrared imaging don't need to be the final answer. This is what you must understand. You doesn't need to say that you have a supraspinatus tendon injury in the infrared imaging, but that there is an inflammation in the shoulder. And this is the point, and this is what we need to go ahead with the treatment or monitoring. You goes without saying that it's a breast cancer in infrared imaging, but there is an increase in metabolic activity. This is sufficiently. Scar high temperature could be infection. Eyes high temperature could be fever. Hyperperfusion could be tendinitis. Increased circulation could be arthritis. Inflammation could be thyroiditis. High metabolic activity could be cancer. Increased sympathetic response could be a neuropathy. A surrogate biomarker is a sign of a specific trouble. In infrared imaging, surrogate endpoints might include things like temperature changes, altered blood flow, or signs of inflammation. This can predict large clinical outcomes, such as whether a patient is likely experiencing inflammation or vascular issues. How you know the patient is experiencing inflammation or vascular problems with infrared imaging. There is no need to have a definitive diagnosis to take action with infrared imaging. Point of care infrared imaging must be fast, must be easy, and must be early. I can use infrared imaging to identify whether we have reached the surrogate endpoint and not the disease itself. I repeat, I can use infrared image to identify whether we have reached the surrogate endpoint and not the disease itself. A clinical endpoint is a specific, measurable outcome we use to evaluate the effect of treatment. For example, in cancer, a clinical endpoint might be the size of tumor after chemotherapy, or might be the decrease of temperature after chemotherapy, or might be the decrease of heat pattern of the number of hot spots, for example. It's a concrete measure that tells us whether the treatment worked. So, infrared is diagnosed? Yes, by the surrogate biomarkers. It's very diagnosed in many ways. For infrared imaging, clinical endpoints could be things like reduced inflammation, improved blood flow, or decreased pain. These are measurable outcomes that show us how the patient is responding to treatment. Compared to traditional biomarkers like blood flow, like blood tests or biopsies, infrared imaging offers a non-invasive and real-time alternative. While biomarkers like serum TSH or autoantibodies require lab tests, infrared imaging allows us to see what's happening in the body immediately, making it perfect for point-of-care diagnosis instantly. Biomarkers are often cheaper and easier to measure than true clinical endpoints. So most of biomarkers are cheaper and easier, and infrared imaging is a very cheaper and easier biomarker. For example, it's much easier to monitor a patient's blood pressure than to assess long-term heart failure. Everybody knows. It's much easier to monitor a patient's surgical post-operative scar temperature than to collect bacteria culture or hemograms. So it's much easier to monitor a patient's shoulder inflammation than to do a repetitive MRI. No sense. MRI every week, no sense. Infrared every week, yeah, sure. Every consultation, sure, is easier. In the same way, infrared imaging provides a faster and real-time way to monitor biomarkers like temperature changes and blood flow alterations. It's a non-invasive way to evaluate physiological process on the spot, saving time and research. Here, example of infrared in a right shoulder pain. So, patient has any lesion, no need to definitive diagnosis. You need to understand that there's inflammation on the right shoulder, and we can do something for this patient. Could be to do an MRI, an exam, or a treatment, depends on clinical evaluation for a specialized professional, okay? A surrogate endpoint is a biomarker that stands in for a clinical endpoint, a measurable characteristic that tells us how a patient feels, functions, or survives. For example, temperature fluctuations in infrared imaging can act as a surrogate endpoint, giving us early clues about inflammation or vascular issues before a more serious condition manifests. Clues, I talk about clues. This allows us to act quickly and adjust treatment in real time, in that moment, and not after. So, according to Austin Bradford Hill's guidelines, we can determine the usefulness of biomarkers by looking at factors like strength, consistency, and specificity. When applied to infrared imaging, these criteria help us ensure that the changes we see in heat patterns, like inflammation or altered blood flow, are strongly associated with specific clinical outcomes. So we need to see the infrared images, the patterns, and associate with specific clinical outcomes. This is the point. To make infrared imaging a reliable biomarker, to study this, to understand this, to publish about this, we need to apply Hill's criteria: strength, specificity, temporality. I explain. Strength. We look for a strong association between heat patterns and the condition we are diagnosed. Association, heat patterns and condition we are diagnosed. Specificity. The imaging must show a clear link to a particular disease, like detecting increased temperature in inflamed joints. Temporality. Changes in heat should match the timeline of disease progression. By following these guidelines, we ensure that infrared imaging serves as a powerful tool in clinical practice. Biomarkers are essential part of modern medicine. We use them every day to stage disease, like the number of lymph nodes affected by cancer, for diagnosis such as serum T3 or autoantibodies, and to monitor disease progression or treatment response, like blood glucose or blood pressure. In the same way, infrared imaging gives us an innovative method to monitor and diagnose conditions in real time, adding a valuable layer in the clinical toolkit. Biomarkers are an essential part of modern medicine, and infrared imaging could be as essential as the blood glucose, as essential as the blood pressure, to monitor and to diagnose conditions in real time. We can do the compression test of the brachial artery in the arm, and this is called endothelial test for cardiovascular infrared risk evaluation in the clinical setting. We can take an infrared image on a painful neck before palpation and go exactly at the myofascial trigger point, for example. Infrared imaging represents a new frontier in the fields of biomarkers, allowing us to assess conditions like inflammation, vascular dysfunction, and chronic pain in real time. By monitoring heat patterns, blood flow, and physiological changes, we can use infrared imaging as a surrogate biomarker, not a definitive diagnosis, but a surrogate biomarker. We don't need to wait for the disease. You don't need to wait for the train to pass over us and we are sitting on the trail road. No, take it off, do infrared image. By monitoring heat patterns, blood flow, physiological changes, we can use infrared image as a surrogate biomarker, just as we do with blood pressure or glucose. This offers a fast, non-invasive, and effective way to improve patient care. Again, here's an example of epicondylitis on the right elbow. So we'll study this. We'll verify the definitive diagnosis by ultrasound, or we can start the anti-inflammatory treatment. We can monitor the situation. Here another example of visceral pain is a hurt pain, stroke. So, but we need electrocardiograms, we need enzymes to definitive diagnose. But it's possible to do a screening. Here's surrogate biomarkers during surgery. So we open, we can see during the surgery if the heart has a specific area of low circulation. It's the same example and a good example of surgical surrogate biomarker scanning. Here's another example of radicular L5 on both feet. So sure, we can do neurological exams, electroneuromiography to confirm or to have all the criteria for definitive diagnosis, but we can start the treatment. We can start to think about this or to understand why the patient has this L5 pattern on the images. We can understand in this case of failed back syndrome, post-laminectomy, it's possible to understand where is the main inflammatory points to start the treatment or to start the investigation. And here, a very interesting case where you can understand where is how is the circulation of the feet on this diabetic patient, and we start to think, oh, it's not good, this situation, and he must need amputation. So infrared image is here showing us a ischemic area, the limitation, the ischemic area as a surrogate biomarker. Another example in fibromyalgia patients, most of them they have many biomarkers. Cold hands is a noradrenergic response mental sign. There's a thermoregulatory autonomic disturbance on fibromyalgia patients. So they have many biomarkers, but the definitive diagnosis is the ACR criteria, the American Rheumatology College of Rheumatology criteria. But we have biomarkers for this, and we can study this. And also vascular diseases. And here we can have very specific biomarkers that is the venous and insufficiency pattern. So thanks so much. And I open here the discussion about if infrared imaging is diagnosed or not a diagnosed test. Thanks so much. And I want to listen to your opinions. Okay, Sidalia, did you understand?
Yes, very well. And a very important thing that you told us is the need to associate this real infrared imaging to the clinical finds, clinical outcomes, because otherwise it won't mean what the physician needs to do. For example, I remember that when I received a patient in my office, he said, I have a terrible pain on my left shoulder. It started about midnight, and it didn't, I didn't have better outcome with some analgesic that I used to use when it happened some time ago. Then I made this point of care approach, and what I saw was the image very, very likely to the one you showed with the hyporadiation on his left chest. Yes. Do you know what I did? Right. I measured his blood pressure. I just said to his wife, please, let's go to the emergency room. I'd like to make some other approach. Yes. And he was having a heart attack, and I saved his life because of this. He had no other symptoms, but he went to the, how we call the exam that, I don't know in English.
Yes.
Hemodynamics exams, okay? Mm-hmm. So that's the way we can save lives also. I'm talking about the extreme point, but every day I use the point of care because I can really see what's happening, what's the inflammation, what's the neuropathy that is happening with the patient, and then join these associated with his clinical and have a very quickly approach to the treatment, to this decision I need. Then after that, I ask for other exams if I need. So thank you very much. This is a very good approach to the patient's complaints.
I try to explain to Julie, if Julie is listening to me, And are you
I
listening?
am here.
Okay.
I am here.
Just this point is very important because many times people want to prove or don't agree that infrared imaging could be used for breast cancer, for example. And the point is that infrared imaging is not specific for the diagnosis of breast cancer, but it not means that we cannot use it for breast cancer. And what I try to bring here on this discussion that we must to understand and study infrared imaging as a biomarker. Biomarker. This is the point. So many of you must to read about this, study about this, and publish papers using this word and understand the science of biomarkers. And we have many advantages here with infrared because infrared is imaging, and most of biomarkers are not imaging. We have many imaging biomarker imaging, but here we have a imaging fast, instantly. So blood glucose is a biomarker, but you must to collect this, to study, to measure. So there are many steps on this process. Sometimes people collect not correctly in the wrong time, so very early or not in fasting, or there's some problems in the lab or would measure something wrong. And Francisco, you know, you work in a lab. So, but sometimes we have many steps on the process that can happen, they have some error. But this not means that blood glucose not works. It works if you understand. It not means that blood glucose is diagnosis of diabetes. No, you must understand the contests. There are clinics, other exams, and you say, oh, my patient maybe has diabetes. And we use every day, a lot of places, nobody contests this. So infrared imaging for breast, for example, or for inflammation or for vascular disease must be the same. Is the first step to understand infrared imaging as a biomarker. And surrogate, it means that we don't need to have the final disease diagnosis. You don't need to, for example, for breast, the right is to have the biopsy or at least the mammography because it's the most conventional student exam. Okay, but we don't need to wait this to have the diagnosis. So the biomarkers, the function is to say, oh, you can do something here. You can change the natural history. You can or start some kind of treatment, but depends of you. Me, why? Depends of your experience. So if you are you experienced on breast cancer, for example? Oh, so you can. It'd be more difficult to go ahead in the monitoring or in the treatment or in prevention or to ask another exams. So it'd be less useful if you don't have experience with that specific point. But that means that you cannot use. You can use and you can document this, but you must understand that someone needs to see this information or see these images, see this, there's something wrong, and someone needs to do the next step. This is the point. So if you separe, or if you separe or divide traditional exams for definitive diseases from biomarkers, surrogate biomarkers, and clues. The clues, we will have a place for infrared imaging in any medical field. Does make sense, Francisco Gonzalez, my friend?
Marcos, can I
Yes,
share
sorry.
something?
Go ahead.
That's okay.
Julie. After.
Yeah. So 14 years ago, being a breast cancer, I don't even like to say survivor, I was diagnosed with third stage invasive ductal carcinoma, and I am 14 years out without any radiation, medication, or chemo. But I just chose to do a lumpectomy because I did all of my biomarkers and all of the testing. And that is what's led me to this industry, because in Las Vegas, we have plenty of women with implants who refuse to do traditional mammograms, which, as you know, in the US now, we have a federal law that's being enforced as of September 10th, that if they have on their radiology report that they have dense breast tissue. So that is what's really leading the industry, I think, much faster now as of September. So with mine, I've shown my thermal imaging, and that's why I ask you about cameras and quality, because 5 years ago, when I looked to get in this industry, so I didn't want to open a can of worms and get into a field that was just hocus pocus. So I did my homework to learn that one, it's not hocus pocus. It's how I monitor myself and my own personal story. Because if I do a mammogram, if I do an ultrasound, it all shows a lot of scar tissue, which they say, uh-oh, scary. But I show them my thermal images and I'm like, look at this. There is no heat. There is no angiogenesis. I followed it. And they're like, well, what is that? And so I think the most important part for us is to educate doctors, is to get out. And what you're doing is this education to understand they're reading things on Dr. Google that is old school and a bunch of crap from people who didn't do it correctly. So when it comes to training and it comes to cameras, those are my biggest concerns when I talk to Ray, who's boots on the ground with the FDA. And that's why I ask you is, I know it works, but I have a camera that's 640 by 480. So I would love to in the future have a discussion when it comes to breast thermography and seeing vascularity or angiogenesis, how important is the camera to, the lens? So if we can cover that, I appreciate it.
Mhm. Go ahead, Francisco, and after I reply,
Yeah.
Julie,
Yeah.
and you. Thank you, Julie. Thank you. I will reply after.
Very interesting presentation. Unfortunately, I logged in a little bit late. I don't know if I missed a lot, but what I saw, it was very interesting. And yeah, one of the what Dr. Julie was saying is very, very true. Thermography is not a diagnostic technique. You cannot diagnose something using thermography because it's not specific. For example, there are a lot of benign breast pathologies that also show as weird or strange things in a thermogram. However, well, you can see there's something wrong, so you have to investigate that further. So that's why, yeah, the FDA approved thermography as an adjunct technique for diagnosis, which means that you cannot just use base yourself on thermography to make a diagnosis, but you can use it to screen or as a biomarker, like you very well said in the talk. So yeah, and education is key. Regarding the cameras, I don't know if you guys introduced yourselves at the beginning, but I'm not a medical doctor. I have a PhD in physics, and my area of expertise is microbolometer. So it's basically infrared cameras, and I do a lot of simulations of heat transfer in biomedical tissue. So which helps medical doctors to diagnose. I personally, obviously, do not make diagnoses because I'm not a medical doctor, but I mean, heat transfer in biomedical tissue is my area of expertise. And regarding cameras, 640 by 480 is good spatial resolution, and something that you need to take into account. It's also like a thermal resolution. Like current cameras can go down to 30 millikelvin, which is very, very good. They can detect temperature differences of less than 0.03 degrees C, which is super, super low. And I have a paper published that tells you what's the difference in temperature that a certain tumor would give you depending on the depth in the breast, because it's not the same thing that the tumor is close to the skin, that as opposed is 3, 4, 5 centimeters deep in breast tissue. So the temperature difference changes. I can give you the website here, Julie. And yeah, but great talk. I can give you some papers that I've published, and Marcos has published.
And you can send me, and we'll put on this video that will stay on YouTube, and we can make a link there or send to everyone.
Sure.
And do you, Francisco, for you, a glucose blood test, is it a diagnosis exam or not?
Well, according to
for you, no, in your personal,
in my opinion,
it's not a test, but for you, a blood test. If the doctor
a blood test, like a glucose. Yes. Yeah, I mean the way of diagnosing diabetes is like a
yeah. Okay, no problem. Yes. Everybody will say, most of people say yes.
Yes.
So we must to say the same for infrared imaging. So infrared imaging is a diagnostic test. Infrared imaging do diagnose. We cannot. I am explaining why. We cannot say no, it's not diagnosed. No, infrared image is diagnosed. Infrared image is diagnosed. I will repeat many times this. Because
the thing is that just one comment. if, for example, Dr. Julie puts in her website, infrared imaging is a diagnose, then the FDA will send her an email
okay,
and she'll get in
we
trouble.
must explain. Okay, let's explain.
But I do agree with you.
No, but
Marcos.
I'm talking science. I'm talking science. So for science, infrared image is a diagnostic test. But what the point here is, what is diagnosis? What means diagnosis? It's very broad. This broad diagnosis, it comes from the Greeks, and they say that is like to distinguish. This is A and this is B, or this is abnormal, this is normal. This is diagnosis. When you understand that you recognize something strange, this is diagnosis. I'm diagnosing something. But we have different levels of diagnosis. Could be something like strange. Could be something like it's very simple. Strange or not strange? Yes, it's strange. Okay, but the degree of strange, low, medium, or high strange. Oh, it's high strange. How much? In the score is 9.8 grades. Okay, and what this means? We go to another level. This means inflammation. Okay, but what kind of inflammation? Oh, it means something very acute, or is bigger, or is vascular. But what is the disease? So the last stage of diagnosis, we understand, not everybody, it's not correct, but most of people understand, no, the last stage is the name of the disease. The name of the disease is breast cancer, for example, or a lesion of the supraspinatus. But all the steps are diagnosed. So we must clarify to FDA, for example, what kind of diagnosis we are doing. So the correct word here, Julie, that we must say there is a biomarker. Understand? With a surrogate biomarker, when we say this, it's a surrogate biomarker, we are putting the things on the right place. So, okay, it's not definitive diagnosis. Okay, it's not against another tradition. No, it's a biomarker. And this way, we have a sensitive, specific, could be sometimes very good and other times not so good so much, or other times not works. So we must to clarify this in our papers, in your publication, when you talk and in our videos. So infrared is a diagnostic test, sure, but better is a biomarker surrogate. And the fact to be a surrogate biomarker, it not means it's not good. It means that it's much better for us. It's much better. So, but you must to understand that I don't work with final diagnosis. I work with biomarkers. I discuss with people with biomarkers, not different diagnosis. So we must put the things on the right. Como é que é gavetas in English? In the right
place.
Draw.
On the right draws. And about the equipment, we must take care of this. Why? Because the resolution not means diagnosis. Resolution not means biomarker. This is something much more commercially than in the real life or in science. For example, we are not looking for a pixel. We're looking at a pixel. Understand? We don't do image so distance. We do the image very close, almost 30 centimeters or more close or a little less. But we need a group of pixels to understand if this group of pixels look like inflammation, or look like a vessel, or look like an area of ischemia. Understand, Julie? So the resolution not means that you have the diagnosis. So if you have a high resolution, it would be more easy for you to understand that something wrong, okay? But the low resolution to a specific level is possible to reach the same diagnosis. So you can do the same diagnosis or the same conclusion. Here, there's inflammation. Here, there's venous stasis with low, medium, or high resolution. It's possible. Sure, I prefer high resolution because it's more easy, more beautiful, and more. But sometimes not need so much. Depends.
Não posso falar agora, estou no meio de uma aula.
So we cannot create a barrier. We cannot create a barrier with the devices. And the technology is showing us with artificial intelligence, with different kind of softwares and different combinations, image processing, that we don't need so much information. You must understand that each pixel is information, is a data. So when you have 1 billion data, billion information is much more difficult and less accurate when you have, for example, 100, 50. So most of the softwares to do that do diagnose automatically, they simplify the process. They simplify and put this on a specific way. So I'm not against high resolution cameras, but I'm saying that the science is not looking only for this point. So we can do science with medium or low resolution cameras too. Okay, so we cannot create here segregation. You don't have, I have, you don't have. No, we must open for the science and prove to the people if this biomarker works with this device or low, medium, high resolution. But it not must be the main point here, because if you have the high resolution camera, it not means that you do the best exam or the best diagnosis, or if it not means that you are right in your interpretation. The point is interpretation is much more important. It's much more important the number of neurons in the brain are you using to interpret the image than the numbers of pixels in your camera. This is the point. Okay. Anyone want to comment something? We have more 2 minutes and we'll finish.
Can I show a picture real fast, Marcos?
Sure.
Let me.
Please. It's okay, Julie. Sorry, if you have any questions, send me an email.
Let's see.
Go ahead, Francisco.
Thank you. So see, Julie, this is a picture from the paper I was telling you. And here's the thermal resolution. 640 by 480 is a very good camera. It's a very good resolution camera. And I mean, the next thing that you can see is that the thermal resolution, if it goes down to 10 millikelvin, 20, 25, 50. And this is a calculation. It's a calculation, a computer simulation. So it's not like with real data, because every person is different and every case might be different, but it gives you like an idea of what your camera can detect. So for example, if you have like one of the older cameras, they have like 100 millikelvin resolution, then you can detect a 10 millimeter tumor that is like buried up to 2 centimeters inside the breast. But if you have like, for example, a 10 millikelvin camera, which is like state of the art, I think it would be like very expensive and very difficult to get a 10 millikelvin camera, then you would detect the same tumor, but if it was like more than 5 centimeters inside the breast. So that would give you like an idea of what you would get with different temperature resolutions. Right now, cameras are like around 30 millikelvin. Probably the one you have, it's like 30 millikelvin or less. And these simulations were made with computer, but I mean, as you can see, they give you a very accurate representation. This is with a cyst. Since the cyst doesn't have perfusion, it looks cold. If a tumor which has metabolic heat generation and it has like higher perfusion, it gives you like an increase in temperature, as you can see here. And this is a comparison of my simulations, which is this one, and this is a real thermogram. So I guess it's fairly close. But this is some of the stuff I do, and I can send you the paper. I'll send Marcos the paper. If you do a web search, you can find it.
With everybody that's taking part here. Very nice paper, very nice.
Thank
and
you,
Francisco, do you have experience with ultrasound, breast ultrasound?
I do not.
Okay, well, we have experience with comparing infrared images with breast ultrasounds, and most of the time, what we find on the infrared image is not exactly in the same place of the original tumor. We have many cases of the tumor is on the right upper side of the breast, but image is on the nipple or not so close to that. So it's very difficult to say that the image has relation with the depth of tumor or the size of tumor, because sometimes it's superficial or is more deep. And so when you're more deep, the location is more difficult to find. So infrared imaging in the practice until today is not something specifically. I cannot do a biopsy, thermo-guided biopsy, because most of the time I not find the tumor exactly on that point. When I find this, for me, it means that, it's late. So it's a big tumor and this is not early tumor. So early tumors, they are not close. So you must take care when we describe in your report that the problems is on the upper side, upper lateral of the breast, could not be there. So because it's a function, it not means that we are wrong, that is not infrared is not useful. No, it's useful, but you must understand how to use, and especially you must understand how to describe this, how to describe, how to put this on the paper, how to do your report, what you're saying. So it's the same thing again. What you're diagnosing, I'm diagnosing not breast cancer, I'm diagnosing vascular problems or vascular biomarkers that is close to a high risk of tumor, and not means is in that place. Or so we must to separate anatomic exams, so that talks about size of tumor or depth of tumor, from functional exams that to evaluate risk. I need to want in my report to know the risk of this patient is high or not. Actually, we use artificial intelligence to calculate the risk, and not just to see the size, the place or what. No, I have all other exams. I have ultrasound, I have thermography, and I need these anatomic exams to eventually to do a biopsy. So infrared imaging on this moment is not reach this level of specificity, but it reach another very high specificity that is to identify very early that we have something wrong here. The clue. So you must to look in this maybe on ultrasound. And when you're looking at ultrasound, maybe you can find this very little or deep or in another quadrant, not in the same. We are looking on the breast. Most of nipple problems, warm nipple. The warm comes from, could be from, come from any quadrants, could be in the inferior or upper quadrants, and the image is only different on the nipple. So this is the message. Okay, we can do other meeting just to talk with breast, and I would like to invite you to send your suggestions for our next medical minutes, and questions, suggestions, and to comment my English. Sorry, training, but we are open here to learn and to share knowledge. I don't want to do only me the next medical minute, because it's a AAT that is providing for everyone, members and non-members, the opportunity to discuss. So if you want to bring your idea or to bring some comments or prepare something, call me, contact with me, and we can schedule it for you to present in the next Saturday or the next Saturdays to the end of this year. We are open for this. And don't forget to take part of our meeting on October 19th. Here is we have the speakers as Rita, that is with us, and Sidalia, that is with us, Lucienne, Sergio, and many other speakers. And we are also preparing some training courses. If you have interest on training courses, please send your ideas and comments for us that we are preparing by the AAT and in the next after the 19 October meeting. Please go ahead, Sidalia, and you can, after this, close our meeting. Go ahead.
Thank you very much for this opportunity. What I'd like to stress and make it like my message for today is that infrared imaging for us must represent a way to go previously to the tumor size. I mean, doesn't mean scan the tumor. For us, we can use this technology to go to look for the metabolic changes, the vascular changes that come before the group of cancer cells can be able to be detected by a mammography, for example. It's not one, not two, not 3 times that I had patients with every year mammography, by right 2, by right 3, nothing wrong, nothing says, okay, you go for a biopsy, and she had a cancer, even though after biopsy, the mammography was didn't tell us this is a cancer, probably cancer. So what we have in infrared imaging is the possibility to see something is wrong here. They are the surrogate biomarkers, okay? Put it in your mind, because this is the main message here. That's why he said it can be a diagnostic tool in the biomarker way to see this. That's the way we can prevent the bad cells to become big enough to be detected by by mammography, for example. Thank you very much. Sorry, my English, but that's the way we can talk to you. Thank you.
Thank you, everybody. Good weekend. Bye. See you the next time. Thank you, Sidalia. Thanks so much.
Okay.
Thank you, Francisco.